Hi, it's Dr. Paika. I am board certified in internal medicine, and thank you for joining me today. I'm really excited to talk about something that's becoming one of the biggest focuses in healthcare, specifically modern healthcare, and that's obesity medicine. Now, this isn't going to be a dry academic lecture. Think of this as a relaxed, honest conversation about what obesity really is and why it matters, and how we as clinicians or even as individuals can approach it with the right mindset and science. Why does this matter? Let's start with the obvious. Obesity is everywhere. Rates have doubled since 1990, and by 2050, experts estimate that over 250 million Americans will have overweight or obesity as a problem. So 2 out of every 3 adults will suffer from obesity, and that's the reality. And yet, despite these numbers, the conversation is still often filled with blame and misunderstanding. People think it's just about eating too much or not exercising enough. But obesity isn't that simple. It's not a moral failure. It's a chronic, multifactorial disease that affects hormones, metabolism, and behavior. So let's unpack it a little bit. How do you define obesity? What is obesity? The medical definition sounds complicated. It's a chronic, relapsing neurobehavioral disease where an excess in body fat leads to metabolic, mechanical, and psychological complications. Basically, it's when fat becomes sick. The body fat itself starts releasing inflammatory chemicals, messing with hormones, and causing all kinds of downstream problems, from diabetes and hypertension to sleep apnea, arthritis, and even certain cancers. The CDC website actually recognizes 13 different types of cancers that have strong links to obesity. So when we treat obesity, we're not treating vanity, we're treating disease prevention. And let's get down to the big picture. Let's zoom out for a second. In 1990, most US states had an obesity rates under 15%. Fast forward to 2022, most states are above 35% now. And the worst affected states are Oklahoma, Louisiana, West Virginia, and the lowest affected states are Colorado and California and New York. And it's probably because, some of the hiking and skiing out there in Colorado. So it's not just the US. Globally, every single country is trending upward. High-income nations were affected first, but now it's spreading to middle and low-income countries as food environments change. And worldwide, women are still affected more than men. So this is not just a health issue. It's an economic, social, and generational issue. And we have to realize that. Now, let's talk about something that's often ignored: stigma. Many patients with obesity delay seeing a doctor because they have a bad experience in the clinic or bad experiences in healthcare settings in general. So as providers, or even just as people, we have to create a safe environment for patients. And that means chairs that are actually fitting, large blood pressure cuffs, scales that can accommodate higher weights, and most importantly, compassionate language. We collaborate, not lecture, because when patients feel respected, they engage more, and that's when results happen. Okay, let's talk about measurement. We usually start with a BMI measurement, body mass index, weight in kilograms divided by height in meters squared. And here's the quick breakdown. Under 18.5 means you're underweight. 18.5 to 24.9, that's normal. 25 to 29.9, that's overweight. 30 and above, that's considered obesity. Then we divide obesity into 3 classes: Class 1, 30 to 34.9, Class 2, 35 to 39.9, and Class 3, 40 and above. But, and this is the key, BMI isn't perfect. It doesn't distinguish between fat and muscle. So a bodybuilder may have a BMI of 32 and be perfectly healthy, while another person at 28 might already have metabolic issues. Also, for Asians, the risk begins at a BMI of 25 because they have higher amounts of visceral fat. So BMI is the starting point, not the full picture. So why do people gain weight? There isn't just one answer. Obesity is a multifactorial disease. It involves nutrition, high calorie food intake, processed food environments, physical inactivity, long work hours, screens, cars, sleep deprivation, which raises cortisol and appetite hormones, stress and trauma, emotional eating, poor coping mechanisms, medications like antidepressants, antipsychotics, insulin, beta blockers, and steroids, and of course, genetics, which can account for 40 to 70% of risk. Even childhood environment matters. Kids without safe outdoor spaces or stable families are statistically more likely to become obese as adults. So when we see patients, we have to ask, what's their story? Not just what are they eating? And let's talk about treatment. Now, when it comes to treatment, we think in layers and we think like a pyramid. At the base, we have lifestyle therapy, nutrition, activity, behavioral change, then medications, then at the top, bariatric or endoscopic surgery. And every patient should start with lifestyle changes to begin with. But not only that, telling people to eat less and move more isn't enough. We need structure, accountability, and individualized goals. Let's talk nutrition. The most evidence-based diet. What is it? Whichever one a patient can stick with that leads to a caloric deficit and a good nutrient quality. Now, that could be a Mediterranean diet, DASH diet, low-carb diet, vegetarian, or even intermittent fasting. Focus on whole foods, lean protein, healthy fats, and fiber, and limit sugary drinks, juices, and ultra-processed snacks. And remember, calories matter, but the quality of calories matters too. For example, 500 calories of chicken and vegetables will keep you full and stable. 500 calories of candy and soda, you'll be starving again in an hour. So we have to teach people to read nutrition labels, and that's very important, not marketing labels. Now let's talk about cooking oils and some concerns regarding that. One common question I get from patients is about oils, olive oil versus ghee versus coconut oil. The short answer is it depends on the patient. If someone has a history of heart disease or high cholesterol, stick with olive oil, avocado oil, or omega-3 fats. If they're otherwise healthy and they're following a ketogenic diet or a traditional diet, then a little bit of ghee or butter can be fine. But again, total calories matter here more than the label on the oil bottle. It's about moderation and medical context. Now, physical activity. The American Heart Association recommends at least 150 minutes a week of moderate intensity exercise. That's about 30 minutes, 5 days a week. Moderate intensity means you can talk, but you can't sing. That's your brisk walk, your cycling, your swimming, all of that stuff. Around 60 to 70% of your max heart rate. So if you want to calculate that quickly, take 220 minus your age and then multiply that by 0.6, and that'll give you your bottom number. For most people, it's not about fancy workouts. It's about consistency. We have to move more because sitting is the new smoking, if you will. And then there's sleep and stress. Poor sleep raises cortisol, lowers leptin, and increases hunger. Chronic stress drives emotional eating. So helping patients build routines around rest, mindfulness, and mental health is part of obesity medicine as well. Sometimes we even need to refer for therapy or psychiatry, especially when patients have anxiety or depression, and those can be tied to eating behaviors as well. Because this is about a whole person care, not just body weight, right? Let's talk about medications for a minute. Right now, the FDA has approved 7 medications for chronic weight management. And you've got orlistat, the fat blocker, available over the counter, Phentermine, an old but effective appetite suppressant. And then we have Phentermine and topiramate combination therapy, which works on the brain and satiety factors. And naltrexone bupropion affects dopamine and reward pathways. Liraglutide, semaglutide, and tirzepatide, the GLP-1 and GIP agonists that have changed the game. Those last ones, the injectables, can lead to 15 to 20% total body weight loss. That's the same range we used to see with surgery. But when the medication stops, the weight tends to return. So that's important to note. So patients have to understand that this is long-term management, not a 3-month fix. Side effects include nausea, constipation, reflux, and rarely pancreatitis. And they're contraindicated in people with a personal or family history of medullary carcinoma of the thyroid. That's important. So you want to ask them about the family history and their personal history. And then finally, surgery. If lifestyle medications don't work and the patient has a BMI above 40 or above 35 with comorbidities like diabetes or sleep apnea, then they may qualify for bariatric surgery. The most common bariatric surgery done today is the sleeve gastrectomy, where around 70% of the stomach is removed. And there's also the Roux-en-Y gastric bypass, which reroutes the intestines and changes gut hormones. These surgeries work partly by reducing capacity, but also changing hunger hormones like ghrelin and GLP-1, PYY, amylin. Patients do need lifelong vitamin supplementation follow-up though. But the health benefits, especially for diabetes and cardiovascular disease, are enormous. So it can be quite beneficial, I would say. So to wrap it all up, obesity is a chronic, multifactorial disease. It's not a personal failure. It's a biology. It's biology, behavior, and environment. Even 5 to 10% weight loss can dramatically improve health. And the best treatment is the one a patient can stick with. And empathy and education are just as important as any medication or surgery. We have to talk about weight because when we change that conversation, we can change the outcomes. Thank you so much for listening. And if you found this helpful, stay tuned for the next session where I'll break it down with the 7 FDA-approved medications in more detail and how they actually work inside the body. I'll see you then. Thank you very much for listening.